completing immune, starting respiratory today. Order of affairs that are there. Okay. Let us finish the immunological system as we entertain our fashionably right on time arrivals. I always call it fashionably late. You make an entrance. I like to do that. Moving on. Okay. So this is okay. You might remember last time we were here, whatever that meant. This kind of stuff we looked at. Okay. A little bit about what goes on, and then I have some other stuff in the other PowerPoint sequence, Marie PowerPoint sequence, just to make sure I cover all the bases. So these are at least what we know of. As you can see, tissues and organs that can be transplanted. And many of these have been, some of these are comparatively new. Bone's been around for a long time. Using bone or donor bone, that I have a fair amount of familiarity with. Corneal transplants have been around for a while. Kidney certainly. Liver, relatively new and effectively pioneered here in Pittsburgh, in the Starzl Institute. Unfamiliar with pancreas. Bone marrow transplants been around for a while. Heart, first successful heart transplant was in the mid-60s by a physician in South Africa named Christian Barnard, as I recall. And again, larger amounts of transplantation are something that really, Pittsburgh is certainly at the forefront of all of these with the Starzl Institute. For the late Dr. Starzl, who came here from, I believe, University of Denver, and really made, really created this area for it. So that's of interest historically. Skin, I was doing skin grafts in my office, full and partial thickness grafts in my office early on. So there was nothing new under the sun about that. And so there's a whole lot of ideas that, if it's donated tissue, as you're going to see shortly, with some exceptions, it's going to be rejected to some extent, or at least fought off to some extent. Might be a better way to describe it. So, I mean, if it's anything that's not yours is foreign. As you're going to see when we get into autografts and isografts, these are the only ones that would not necessarily lead to a rejection. An autograft was the ones I did in the office. We call it, another name is autogenous. Auto means self, obviously. And so if you're taking tissue from yourself, and as we do with most skin grafting techniques, from areas with wider amounts of skin that we can even amplify and put it on smaller areas for coverage, that's been around doing that for a very, very long time. Okay, since it's self, it should be, assuming it's handled properly and not damaged, or foreign material is introduced, you should tolerate that, depending on the technique, very, very well. Isografts, and not everybody, and having an identical twin is rare, obviously, but with some limited exceptions, identical twins are, and there's some odd, they're called chimeras, where they actually have some different genetic material in different areas of their body. That's a comparatively rare phenomenon. Not you have to know any of that stuff, but that's what an isograft is. Iso means same, auto means self. So self and same. The vast majority, when you're looking up here about bone, kidney, liver, bone marrow, they are allografts. Allografts mean from one person, from a person other than your identical twin, same species, which may eliminate some of the students I've had over the years. One smile, the rest of you are still asleep. Could have made up for the morning, Allie, if you had smiled on that one. We'll try it again. Allograft means it's from the same species, which would apply to everybody except for some students I've had in the past. We couldn't identify their species. Forget it. And xenografts from different species. Okay, and they've been around for a while. We've used a lot of grafting materials from various animals that have certain degrees of compatibility, if you're interested historically with red. So it's all immunologically active, and that's where the graft and the host have about, and the rejection phenomena is very much, these are about foreign cells transplanted, the same type of thing. This is T cell based on it. That's why when we do transplantations, these folks are typically on immunosuppressive drugs for the duration. So it's nothing easy about this. There's no magic from this. That's there. When they're using allographic tissue from even a highly compatible donor, you're effectively, the rejection phenomena is ongoing, and so it's never an easy road necessarily. So well-matched transplants may not require lifelong. Bone marrow stem cells from the donor are given along with a transplant. And again, these are changes in the technique. But for the longest time, there was lifelong treatment. So be aware of the problems that are associated with it. They summarize that here. Again, heart valves from a pig have been around for a long time. Comparatively, we were using porcine grafts for tendon and rebuilding tendon and ligament apparatus ages ago. And periodically, they're in favor and they fall out of favor. You find that in medicine, we kind of go through cycles of things that are popular and then for whatever reason fall out of favor, and they kind of ramp themselves up again. So it'll behoove you to be familiar with this. This is an interesting area. These are the autoimmunity, and because of that, autoimmune diseases. A very significant topic, well beyond the scope of this course. We could dedicate a whole course, indeed, a whole term or a whole year talking about immunological disorders. They are, and the interesting thing is a vast majority of the students in this class, because again, when I teach anatomy and physiology, the vast majority are nursing and health science students. Women predominate. Who are at the greatest risk for this developing? Women in what we call the 2nd through 5th decades, 15 through 55. That's prime time for autoimmune disorders to rear their ugly head. Understand that. Okay. And I know a great deal about this subject historically and currently, as we begin to see, we know certain diseases favor women and certain diseases favor men, but statistically speaking, 3/4, 80%, in my hands, it's 80-20 women to men. And most of the ones that I'm talking about are multiple sclerosis, systemic lupus erythematosus, rheumatoid arthritis, all of these very significant and highly problematic diseases were part of this picture. I'll give you the lowdown to give you the idea of how this is. So yes, I'm going to turn on the lights. Lights storm. With the scatter. Maybe I did this before, but it always behaved helpful. Do it again. We have here a bell curve. Living systems generally, with some exceptions, behave bell curve. This would be severity. This would be the population. Yeah, that's severity. This would be frequency. This would be the severity. You don't have to know. I'm not going to ask you about it. But effectively, what's a bell curve? So typically when you scale a test, when you're looking at things like that, you probably had a little bit of statistics, standard deviation from the mean, and all those measures, like mean, median, mode. Look at this. I think mode, I think pi. 3.1415 with algorithm. PIE. Okay, so what's a bell curve? It means basically it's like that. Normal measures, not very accurate, 40, 40, 10, 10. So minimal math. It's a pretty very useful chart for people who are going to take care of other people. Somebody comes to you with MS, lupus, rheumatoid arthritis. Here's where they fall. 10%. So this is the good side. 50% of the people are on the good side. What does that mean? 10% carry the diagnosis, but that's all they carry. They have enough scientific evidence to be diagnosed with a disease, let's say rheumatoid arthritis. It does not affect them, other than they carry the diagnosis. So it's like, hey, I got that diagnosis, but I'm, nothing else. I make no life changes. Another 40% on top of that 10% are able, it doesn't really impact them, it only impacts them minimal. They have to take medicine, probably. They do their regular job, sure. Are they scared? No more than you would expect, but they're highly functional. If someone in your orbit or you yourself has this diagnosis, that's the side you want to be on. Side over here. Okay, we'll start with the 40%. That's 40% of that, or 80% of that half, the bad half. It impacts what are called their ADLs. Or ADLs. Oh, a term you're going to become very familiar with. All of you in nursing. Activities of daily living. Okay, the whole purpose of occupational therapy. Someone's going to become an occupational therapist, and that's what you're interested in, all healthcare science individuals. That means activities of daily living are things you and I probably don't think about. Going in the bathroom, taking a shower, taking a bath, getting dressed. All those types of things. Putting clothes on, going to the kitchen and making something to eat, taking out the garbage, all that, whatever. Imagine what happens when you can't do those things by yourself. That's activities of daily living. Half of those people, 40%, it impacts those. So not only do they have to take the medicine, so they're going to have a difficult time functioning in society. They're going to need assistance. And the other 10%, you don't want to think about. The other 10%, very severe, to the point where we're almost talking about total care. So there's a wide range. So the fact that somebody has a diagnosis doesn't mean that they're impacted. And the fact that somebody, my aunt, so whatever, has rheumatoid arthritis and he or she can do this, or my Uncle George has it and he can do this, doesn't mean somebody else won't be severely impacted. There's no clear-cut way of analyzing. I was still a student my last year. 6 of us, we used to do external rotations. We went up to a place called Moss Rehab in Philadelphia, big rehabilitation hospital. And we were with this rheumatologist showing us ropes, and we're going patient to patient. This is what doctors do. They'll take other doctors, residents, and they'll examine the patient. They'll show you'll examine the patient, you'll discuss it. And finally, we got to one room, and he said, we'll go in. I don't want you to say anything. Be very, very quiet. And it was a 2-bedroom, but only one bed was occupied. The bed by the wall. I don't know how to describe to you. There was what was maybe 85 pounds in a fetal position, a person making those kinds of sounds. And he came over, and there was a sufficient amount for me to decide that it was female on my own. I didn't mean to use it, but that she was female. And he reached over and he whispered a couple, and he started to move. Obviously severe pain. He said a few more things and then sort of pointed to us that way. And we waited outside. He came back down. We walked away from the room to a little meeting. That young lady, he said, how old do you think she is? And we were like, hard to get, nobody could get age. Because she was in her early 20s. He goes, 6 months ago, she has severe rheumatoid arthritis. 6 months ago, she was just like you. That's how severe the progression was. And she will not be here in 6 months. Cemented in your mind. We were all of us stunned because we were so used to seeing, all the other patients we had seen were obviously there were many who were impacted or had undergone surgery or that type of thing. But to see someone, he described this was a young woman in her 20s who was just like you and I 6 months ago, and then this flared, to the point where it just overwhelmed everything. That's to give you an idea of your immune system. So that's the backstory for this. And I hope you appreciate the anecdote. I tell it all the time, but it's for real. And you're going to see, and if you're in a career with medicine, I know not everybody is, it's not easy. There are just days when you go back home and you kind of shake your head and go, why am I doing this? You get plenty of those. Against yourself. That's what it means. Autoimmunity. Immune system does not distinguish self from non-self. A lot of times it's antibodies attacking healthy structures. Sometimes it's cells like killer T cells, cytotoxic T cells that are misprogrammed for whatever reason and start attacking healthy structures. Sometimes it's a combination of those things. The damage is remarkably severe. So here you can see antibodies, cytotoxic T cells, and they vary from what impacts them. Okay, and there's a lot of theories, and again, the word theories there is used advisedly. We don't know. MS, there's a strong tie-in. My micro students heard this. There's a statistical correlation with certain aspects of the disease that we call roseola, which is a herpetic virus, human herpes type 6, and multiple sclerosis. Is there a cause and effect relationship? Never established. Does it might be impactful? I mean, that's sort of up for grabs. We didn't think diabetes was an autoimmune disorder. Now, diabetes type 1 is considered to be autoimmune because we see these deposits, which are these antigen antibody complexes we talked about before, which are commonly seen in lupus, by the way, particularly in the kidney. Diabetes is the number one cause of kidney failure and need for transplants. Systemic lupus erythematosus is number 2 on the like that. So we don't have all, but just some ideas. Kidney cell antigens that resemble streptococcal bacterial antigen. You're all working in micro. Okay, you just finished doing throat cultures. Did you guys look at your throat cultures yesterday? Did anybody have streptococcal? Did your blood agar plates turn neat, interesting colors? Browns, greens, could you see through them? Well, if you see through them, that's called beta hemolysis, something my lab is going to discuss tomorrow. Okay, Staphylococcus and Streptococcus can both create beta hemolysis. That's why did you do the bubble test, the catalase test? Okay, so if it's catalase negative and you can see the hemolysis, guess what? Streptococcus does most of its damage by the immune system. It classically produces autoantibodies, most notoriously, creating things like glomerulonephritis, creating things like rheumatic fever, bizarre toxins that produce what we call cytokine storms. And these cytokine storms it's like your helper T cells, 20% of all your helper T cells went crazy and released tons of cytokines. And because of that, this outpouring of chemicals is extraordinarily destructive. That's one of the ways that scarlet fever does its damage. People would die from these things before we had the advent of antibiotics. I can't get through to you the severity of this. That's there. And that's all from a relatively common germ, Streptococcus pyogenes, good old strep throat. That's why when I was a kid, maybe I told you didn't go to the doctor routinely. Doctors cost money. Health insurance did not exist. Did not. Medicare did not exist. Any of those things. And what happened was your mom, if your breath smelled horrible and you got the flashlight out and your throat looked raw and red, that's when they would take you to the doctor because they knew you needed antibiotics. Okay? That's why the catalase test, it's not aerobic, it ferments, foul-smelling breath, da-da. Those are the things that you did seat of your pants medicine back in those days. Glomerulonephritis is commonly occurs, and we'll do this in my micro class. Yes, not just from strep throat, which it can occur from strep throat. It builds up these antibodies, these kidney cell antigens, and they're attacked, because they resemble and so the kidney has one response to any damage. It shuts down. So, and the most common cause of it is a very common skin disease that many of you had called impetigo. And impetigo can be either staphylococcal or streptococcal. My stepson, who taught here for about 5 years, okay, teaching physics here, when he was in high school, got that from a strep throat, not from the skin version, from typical strep throat. Right before they were supposed to, we went to Seneca Valley up in where we live in Cranberry Township and the surrounding area, where they were having like the band or the choir concert and competition. Kidney shut down. Fortunately, it relented. This is one we saw a little bit with the thyroid. Okay, all of the things is like the thyroid gland engines near thyroid stimulating hormone receptor causing overactivity. So you're producing antibodies that have, if anything, don't damage it as much as they generate increases in activity. Diabetes, targeting pancreatic beta cells. Various kinds of hemolytic anemias are part of it. MS. And MS, myelins in the peripheral nerves and in the white matter of the central nervous system. So those white matter are targeted. Multiple means many. Sclerosis means hardened areas. And the nerves don't function because they're really transmitting the signal. Okay, myasthenia gravis. We talked about that, you might remember, in AP1 with regard to the neurotransmitters and the receptors on the neuromuscular junction. Okay, we think that people with true pernicious anemia, not one that's like I got acquired from stomach surgery, but true pernicious anemia, don't make something called intrinsic factor. Okay, rheumatic fever, again, streptococcal, rheumatoid arthritis, deposits on joint linings, etc. Lupus affects all different connective tissues. And we're going to talk about ulcerative colitis and Crohn's disease. They're brutal, and this is just part of the list. I had one that was more common in men. Okay, it's in the family of things that are known as psoriatic arthritis, which a lot of people get, and ankylosing spondylitis, which typically affects your spine. Mine was very central. And I have it still, but I just don't take. I was saying I was uncomfortable with the medications for it. So it is such a fascinating topic. I just want to acquaint you with the severity. Here's one that most people ask about. Okay, it's slow by definition, 2 to 10 years. Okay, and it progresses to age where your immune system collapses. In short, not only does it attack macrophages, the big players that it attacks are helper T cells. And what happens is those helper T cells no longer function as helper T cells, but little factories to make more viruses. And over that 2 to 10 year period for a typical person, sometimes longer, sometimes much slower, who's either been untreated or undertreated or inappropriately treated, okay, they will develop AIDS, which means their immune system will collapse because their helper T cell levels have fallen below the bottom level that can be tolerated, which I think is 200 per microliter, but I digress. I don't know for sure. The helper T cell numbers decline. B cells don't work. The cytokines that the helper T cells make are not present, etc., etc. Okay. Then eventually cytotoxic T cells get damaged, and effectively you can't suppress cancers. People die of what are called opportunistic infections. That means because your immune system is no longer competent, that we inhale fungi and viruses all the time. How they discovered and made the correlation between this virus and this condition we now call AIDS is they saw a fungal pneumonia that a doctor observed in many of his patients who were gay men in San Francisco, called pneumocystic, and now it has a different name. It was PCP for pneumocystis carinii. And now I think it's pneumocystis jirovecii. You don't have to know anything about those names. And it was something that normally fungi that we inhale and exhale doesn't affect us. But their immune systems were so faulty, these men, that they couldn't tolerate it. and if I haven't told you, I will tell you now all again. I'll tell the next class. We were seeing this in Philadelphia. San Francisco and Philadelphia in the 70s had the largest per capita population of gay men. And you have to understand it was very different than today, and tragically so, because people couldn't come out. Okay? They would lose their jobs. People would shun them. We had no tolerance for their alternative lifestyles. But I don't want to make a class about sociology, things like that. And maybe I shared it with you already. That was the first thing with my wife and I started living together. My first wife and I lived together and then subsequently got married. The first thing she says, my downstairs neighbor, I'm his date for the company dinner, the Christmas party, the awards dinner, outings, because he's gay. And he'd lose his job if he was bringing his significant other. So I'm in. And she said, I hope you don't have a problem with that. I said, no. I mean, frankly, why would I? Why would I want to be trying to think of the right term, asshole, and cause somebody to lose their job or alter their life or something like that? I did, but in our orbit, we saw so many gay men who retrospectively suffering from AIDS. All they knew, they called it, he's got it. He's got it. We could see it. All they had was a term for it. It was it. It was some terrible disease that was going around that nobody had a name for. We saw it. One of the markers is a thing called Kaposi sarcoma. I saw 2 cases in 6 months. Most doctors don't see more than 1 case in a career. I saw 2 in 6 months. So it gives you some idea. And I remember having this discussion with the nursing faculty when we were talking about what we should be teaching you guys who are in nursing, so we didn't go too crazy. And I'm saying to them, listen, before they had a name for AIDS, I was seeing it. Well, I tell all the students about this. So you're getting it too. And you all know contaminating blood or body fluids. And there's so many different ways. We talked about it a little bit in repro. This is one of the things why prenatal care is so important. A mom with active, normally you want to frown from you taking antivirals during pregnancy because of a lot of the problems, but they are much more valuable. You can reduce significantly the likelihood that the unborn child will be born HIV positive. Really, and in very severe condition. So just to give you some idea, function declines early in life as the thymus gland shrinks. So it's the system function. I know it's not as powerful, but I don't think that it's that relevant to us because most of the programming is done early on. As you get older, certainly it decreases. And the problem is, like in my particular instance, sometimes adverse things tend to increase then. Okay, all of these are things that we see as a person ages. Thankfully, from my perspective, just talk, because the best context I can give you is me, is, 20 years ago, I didn't take care of myself, okay, at all. Smoked, addicted to pain pills, thankfully didn't drink, high stress, ate everything, way overweight. Who else? Why would I have been at the gym last night at 8:30? Certainly not because it was fun. My wife was in a very bad mood because the Pirates were not hitting anything. I figured it was better than she'd be mad at me. I did go with that. So all of these types of things, you can read them as well as I can. Antibody responses are slower. Okay, oil antibodies, some of these increase, some of these decrease. Vaccines, okay, and then older people don't want to get vaccines. They're stuck. Believe me, they're tired of getting stuck. I know I am. I don't want any more. Okay, so all of those types of things play a role. That's an interesting way to sort of summarize it. I think there's a little bit more here in the other PowerPoint from here. They talk a little bit about some of these immunodeficiency or immune problems here, maybe amplify it a little bit. Congenital or acquired conditions. This SCID is the acronym. a genetic defect with marked deficit in B and T cells. It has to do with a particular enzyme you don't have to know. Now we have bone marrow transplants. This was the original, what they called the bubble boy phenomenon, where they had people who were born with this could have no, had to live completely isolated from outside world. When John Travolta was very young, he actually played this in a movie back in like the 70s. He had that particular role, and did a rather funny Seinfeld about it. There's a TV show from some time ago that was well known. Did you ever hear of it? Bless you. And Hodgkin's disease, when you hear about this, cancer of B cells. So that's lymph node cancer, if you want to think of it this way. Here's the HIV thing. This was, they were talking about the pneumocystic pneumonia. This is what I saw, the Kaposi sarcoma that was there. We know how it's transmitted, its effect on helper T cells. Approximately 10 years if untreated, that would be the top end. Like I said, 2 to 10 is pretty much consistent. And there's a lot, unfortunately, late stage AIDS patients, there's characteristic changes we do see in the brain. You have age-related dementia. It's not a pretty sight. So, and some people it affects sooner than others. If you look at, you can find it easily online. Look at Freddie Mercury, lead singer of Queen, doing the concert in 1986 at the old Wembley Stadium, and then look at him in about 2 months during his last song that he sings, and the transformation is unbelievable. How severely ill this man became in a relatively short period of time. I mean, he went to full-blown age, had a very hedonistic lifestyle, at least. Very. Some very remarkable parties. So moving on, and again, we were not going to go into about the virus and how it does, and yes, we don't. But now 4 major classes of antivirals in combination. Now we use a 4-way antiviral treatment. This is the autoimmune production of it, autoantibodies. Okay, so you can see a lot of these types of things. Immune system loses ability to distinguish self from foreign, either autoantibodies or T cells. And again, all of these ones that now we are, consistently, it went from being presumed to be now current medical science. These are classified as autoimmune diseases, variety of treatments. Now we're beginning to see these much more advanced biologicals, though I don't particularly favor them. They're very useful for people with severe disease. I can only imagine that has made their lives considerably easier, that are there. And this gives you the ideas of how it happens, caused by a variety of things. And a lot of it is we don't know. And we did the number with the hypersensitivities and the allergies, et cetera, et cetera. That's the anaphylactic shock one. And I urge you to kind of go through and take a look at these that are there. This is the subacute being ones. That's you might recall that. And then that's the mismatched blood transfusion. These immune complexes, that's where lupus comes in. And maybe after rheumatoid arthritis, lupus, and there's different presentations that are associated with it. But one of the big problems is there's a number of diseases. Mononucleosis would be one of those. Syphilis would be another one. And those have, one's viral, one's bacterial. This is autoimmune. We call them the great masqueraders, meaning it's not an easy diagnosis. I mean, a lot of times it's innocuous as a sore throat or feeling ill. I mean, there's a lot of, how should I say it, inconsistency with the presentation that's there. So they could look like one thing. It's not an easy diagnosis. Yay, we're done. That ends the immune system. Happy dance. So I was asking around earlier about respiratory, and I have to review some of the anatomy. This starts, and this is so. When I sent you the thing for our exam, the study guide, respiratory was not on it. Is that correct? Right, the respiratory is on the final. For my advanced physiology, respiratory is on exam 3. I don't want to burden you with, you got enough stuff with that. And yes, we're going to do it on Blackboard. Brooke threatened. She did. Oh, stop. You're looking very contented. She already complimented my shirt today. Yeah. I'm not someone who gets clothes compliments very often. Oh, your daughter's gorgeous. I knew that. Okay. Enough Botox, you can fix anything. My daughter's very naturally pretty too. But it's okay. I'm like anybody else. Just I can take a compliment with the best of them. Okay. Respiratory. I'm going to focus more on the physiology. There is some anatomy we have to get into. That's important. When we start to get into systems like, in the last 4 systems are respiratory, digestive, urinary, and repro. So there's what to do. So I may have to record some of the anatomy because I know you've done some of it in lab, or we'll be doing some of it in lab. And but I have to give you points of emphasis that are important, I think, for understanding. Respiratory can be explained very easily in one phrase. All about respiratory physiology. Are you ready? In with the good air, out with the bad. That's respiratory in a nutshell. So it's a system we inhale oxygen-laden air proportionally and replenish the oxygen supply, which has become limited in our red blood cells because we need tons of it constantly. And we exhale a principal waste product of carbon dioxide with some other odds and ends. Okay, that's it. Oxygen in, carbon dioxide out. Not so big. It's not so complicated. To understand the nuances of it, I understand. Okay, so we're going to look at anatomically. We have a system that's designed both structurally and functionally. Did you go over this in lab? Did you talk about the anatomical and the physiological aspects of the division? Okay, anatomically, if you didn't, just to review, if you did, we call the most common diagnosis in medicine URI, upper respiratory infection. What does that mean? Depending on the author you read, dividing line is the larynx. To me, if it starts in your nose, your throat, sinuses, ears, upper respiratory, even if you get laryngitis out of it. It starts with laryngitis and gets into your chest, lower. The larynx, most authors will say the larynx is the start of the lower respiratory anatomical divide, so to speak, would be the larynx. One way or the other. I won't, I'll say the larynx. What's the dividing line with the larynx? That's one of the different. The other one has to do with functional. And for our purposes, functional is more important. It's divided into 2 systems. One is called the conductive division. And the other is called the respiratory division, or exchange division. And the vast majority, structurally, is conductive. The whole purpose of that division, starting with your nose and your mouth and your throat, is to bring the air in deep within your lungs until it reaches those structures called alveoli, which is where the actual exchange takes place. So the conductive division takes it into such close proximity with all those alveolar cells that I'm sure you've talked about a bit in laboratory, that at that point, you don't have to bring the air to them. At that point, the air, the oxygen-laden air is so close Okay, simple diffusion takes over. So conductive is moving the air, and then when you get to a point here, good old simple diffusion takes over. You don't have to provide an impetus or in this case pressure changes, which effectively are the same thing as concentration gradient, by the way. So that's it. Other things it does in the process of doing that, it's a whole lot easier if you filtered the air, if you warmed it up, and you added just a touch of moisture. That's kind of what happens in your nose. You filter it through those nose hairs, right? They catch all the bad stuff. There's a certain amount of moisture that's associated with mucus and saliva. Okay. And the fact that it's going from whatever room temperature is, you're warming it up to body temperature because temperature influences the efficiency or efficacy, if you want to use a fancy term, how well the exchange takes place. Makes sense, doesn't it? I love this. Easy to understand. Yeah, vocal sounds. Yeah, it's just smell. Yeah, the gym last night. So what do you do when I'm increasing my activity level, my speed and elevation on the treadmill? What do I do to compensate? I breathe a lot faster. I'm blowing off carbon dioxide in order to compensate for the pH. Okay. So effectively, I know I'm becoming acidotic inside. If I blow off carbon dioxide, that helps. We'll get into it. We're going to go back to that carbonic acid equation, and your basic buffer. You don't have to thank me. It's part of the service. So exchanging gases. To me, there's two. They call it classically external or ventilation or breathing, to me works best in the lungs, internal at the cells. So as far as I'm concerned, there's pulmonary respiration, in with the good air, out with the bad, at the lung level, and then internal or cellular respiration, basically taking that oxygen into the cells along with nutrients, picking up carbon dioxide and waste products along the way. Voila. That's what happens. So respiration, exchanging gases between the atmosphere and body cells. Okay. And by definition, you and I, again, are aerobic. Our cells would do what with the catalase test? We'd be positive. Our cells have catalase in them. Because anything that's aerobic has catalase in them. Because oxygen, you might remember, oxygen, when we utilize it, all aerobic or partially aerobic organisms create toxic derivatives of oxygen. One of the enzymes we deal with that with is called catalase. It works on hydrogen peroxide. So and here, you can see the dividing in this particular textbook. They have the larynx in the upper. That's my kind of category, but it is the divider. If you look at the other texts I use, Marib, larynx will be in the bottom. So it depends. So all that tells you is no one knows what they're talking about. In the lower, the trachea, all the divisions of the bronchi, and finally into the lung itself. And we're talking about the lung. And you blew up a lung. What, last week you were pumping it and all that good stuff. The lung's just a big membranous tissue. There's nothing, it's not hard on the outside. It's filled with air and cells and blood vessels. The only thing that's rigid in the lung are the bronchi that still have cartilage in them. That's the whole rigidity that are there. Did you like the sheep? It has like that third lung, that little extra piece of lung that blew up. Did you see that? Did any of them explode? Oh yeah, my students always try. I don't want to blow it up. What would the sheep say to that? I know what the sheep would say. Bah. Right? God bless. Somebody appreciates my humor. Not my nemesis in the second from the last row. Voila. Okay, you had anatomy. What's that triangular cartilage called? That's really important. It's very sensitive. Why we cough when particles get down there. Okay, Because basically, what do the bronchi do? They fork, right? Do they fork identically? No. The right one points downward. The left one has to make a sharp left turn. Why? The heart's in the way. So that's an anatomical basis for disease. Most pneumonia is right-sided. The name of that particular piece of cartilage is called the carina, Carina. The other anatomical basis for disease is right here in your ears. You're born with I'll end with this. You're born with eustachian tubes that are horizontal. When the baby sleeps on their back, what happens if they have some mucus or the start of a cold? It drains right back against the eardrums. By about age 4, they're declinated enough so that when you sleep, it's closer to adult. That's the anatomical basis why babies all the way up to roughly age 4, not a hard and steady number, but around age 4, are very, very predisposed to middle ear infections. The same reason why right-sided pneumonia. It's the anatomical basis for disease. You understand the anatomy, it helps you understand the disease mechanisms. Bye-bye. Bye bonds. Sure.
Is there a date for the exam?
Not yet. I'm thinking Friday I should know.
Okay.
And I'll probably email everybody anyway.